Thanks for the question. So, overtriage happens when a situation is treated more serious or urgent than it actually is. So, it's when a patient is assigned a higher triage acuity score relative to what actually happens to them during the emergency department visit in terms of the number of resources used and whether any emergency medications were given. Um, so, with respect to which types of patients, I think in my own clinical experience in that young age group, it's often children coming in due to concern for aggressive behaviors or trying to harm others. Sometimes these are children who have autism spectrum disorder, who may have limited communication abilities, and sometimes the way that they express their needs is more physically. So, this is a growing segment of the population that we're seeing in the emergency department as rates of autism spectrum disorder increase. And I think sometimes the triage nurses are apt to rate these children with a high acuity score so that they can be seen quickly. But at times, they actually don't end up needing many substantial resources while they're in the emergency department, which results in an overtriage. So under triage occurs when a patient who needs immediate care is not recognized as needing it right away. For example, if a patient arrives that has a serious condition and they're assigned a low priority triage score, in those cases, sometimes they can end up waiting longer than is safe to do so. And that can result in adverse outcomes such as elopement from the waiting room, or escalation in the waiting room, which could have impacts on the safety of staff and other patients and families waiting. We found that rates of under triage were higher for Hispanic and Black children relative to white children, and also for families who prefer Spanish relative to English. So this highlights important potential disparities in care with subjective judgment sometimes occurring in these high acuity, high pressure situations. And that influences some of the decisions being made in an adverse way. There are practical strategies that can be taken to try to address these biases in care. And that includes training staff on implicit bias. Implicit bias is unconscious beliefs or attitudes that may manifest in the decisions that are made in a clinical space, especially when there's pressure to make fast-paced decisions. And so receiving training on implicit bias and having increased awareness of its possibility can help you to overcome that unconscious bias with conscious thinking. Another concrete strategy would be to improve use of professional interpretation services in triage. So it's possible that some of the rates of under triage we noted among families who prefer Spanish are due to miscommunications during that initial communication between the family and the nurse in triage. If we can make sure that we're asking families their preferred language up front and always use a professional medical interpreter, that holds the potential to reduce miscommunication. The Emergency Severity Index is widely used across all emergency departments, but it is updated every few years to align with the most recent evidence. One area that our team is exploring is a different triage scale that's currently in use in Australia for triaging patients who present to the emergency department for mental and behavioral health reasons that provides more concrete guidance and anchors on how to assign acuity scores based on observed and reported behaviors related specifically to behavioral health symptoms. So I think there may be opportunities to revise and provide more detail in the Emergency Severity Index Handbook, as well as increased education for nurses across the country on how to appropriately assign triage scores for children presenting with behavioral health symptoms. Ultimately, I think more work is needed to understand how to better design and implement triage systems that can reliably match resources to patient needs for children with behavioral health symptoms. So over triage means again that Children are being assigned a higher priority score than needed based on their true needs. In our study, we found that more than half of children presenting with behavioral health symptoms were over-triaged. So when over-triage is widespread across a health system, it diverts resources away from the children who truly need them, and can strain limited emergency department resources. On the other hand, under triage can result in important patient safety issues, such as elopement or behavioral escalation while waiting. Right now, the Emergency Severity Index provides fairly limited guidance. It recommends assigning a score of 2 to any patient at risk of harming themselves or others. But there's, other than that, not much more specific guidance on how to assign a score from 1 to 5. In contrast, some of our colleagues in other countries, such as Australia, have much more detailed anchors for observed and reported behaviors that can be used to more objectively assign a triage score for a child presenting with behavioral health symptoms. Those include, for example, whether the child is acutely agitated, violent, or in restraints upon arrival, whether they're having urgent or acute suicidal thoughts, if they had a recent suicide attempt, if they're exhibiting symptoms of paranoia or delusions. In contrast, examples of lower acuity presentations could be patients who have mild depression or anxiety but no suicidal thoughts, or patients who are having difficulty accessing care or medications. For example, a patient presenting for a medication refill. So if we had more specific anchors and guidance on how to assign acuity scores, then that could increase the objectivity of the assessment and reduce the potential for bias in applying scores differently based on patient demographic characteristics. So I think another important research direction will be to think about the potential of using artificial intelligence or AI tools to assist clinicians in making triage decisions. Um, there is potential for these tools to help standardize decision making and incorporate objective data in order to increase accuracy of triage. On the other hand, I do think that AI tools would need to be carefully validated and monitored to make sure they don't reinforce existing disparities and that the clinical judgment of the triage nurse remains central.